We all remember those childhood spills,
Yeah.
right? Little tumble in the playground, maybe a scraped knee, usually no big deal.
Yeah, exactly.
But as we get older, or, if neurological issues come into play, the simple act of falling becomes a really significant health concern.
Absolutely. It's easy to think of a fall as just, well, an accident, but the sheer scale of the problem is quite alarming.
How big are we talking?
Well, in the U.S. alone, over a quarter of adults aged 65 and older experience a fall every single year.
Wow, that's huge.
It is, and that's a massive number of incidents leading to millions of injuries, hospitalizations, and an enormous drain on our healthcare resources. We're talking billions, literally billions of dollars annually.
So fall-related injuries are right up there.
Oh, yeah. They rank among the most costly medical issues we face.
Okay, so let's really get into this then, because when we say fall, it can mean so many different things.
Exactly.
Sometimes it's a trip over an uneven sidewalk. Other times it's something, well, far more sudden and unexplained. So for this deep dive, our goal is to really understand the different kinds of falls. We're going to look specifically at those, accidental trips versus what are called drop attacks.
Right.
We'll also be exploring the potential medical reasons behind these, based on some really interesting research, and figuring out what makes some people more vulnerable, especially older adults and those with neurological conditions.
Yeah, the aim is to give you, the listener, a much clearer picture of this, well, pretty complex health issue.
Okay, and maybe we should define a couple of key terms right off the bat.
Good idea. So first, a drop attack. This is a sudden fall that happens without any warning signs whatsoever. No dizziness, no feeling faint beforehand.
None at all.
Nope, it might even involve a temporary loss of consciousness. And importantly, this kind of fall isn't something you could prevent with, say, a walking stick or a walker. It's like your legs just suddenly give out from under you.
Okay, so it's not a stumble caused by something external, like tripping.
Yeah.
And the other term?
Just fall, which is basically when you find yourself unable to stay upright, when your balance is challenged in some way.
Got it.
And as we delve deeper, it's crucial to remember this. The first step in figuring out what's going on is to distinguish between these two scenarios, a sudden, unprovoked drop attack versus an accidental fall where there was a clear trigger.
All right. Let's tackle those more mysterious ones first. The drop attacks that involve a loss of consciousness. The first thing that comes up is syncope or fainting.
Mm-hmm.
We often think of fainting as just, a temporary thing, maybe feeling lightheaded first. But it sounds like it can lead straight to a fall.
It certainly can, and in severe cases, it can point to significant heart problems.
Like what kind of heart problems?
Well, think about situations where the heart suddenly starts beating way too fast or chaotically. Those are ventricular arrhythmias.
Okay.
Or it could be severe hypotension, low blood pressure, or even a sudden, complete, they're usually temporary, stop in the heart's electrical activity that's called a Stokes-Adams attack. These events can cause a critical drop in blood flow to the brain, leading to unconsciousness and a fall, often without any prior warning.
So no feeling faint beforehand necessarily.
Not always. While other, less severe heart rhythm issues usually do come with pre-fainting symptoms like dizziness or lightheadedness, it can be tricky.
How so?
Well, particularly in older adults with a condition called sick sinus syndrome, their memory of those warning signs might be unreliable. They might not recall feeling anything before they went down.
Ah, okay.
And it's not just rhythm problems. Less common heart conditions like aortic stenosis, that's a narrowing of the main heart valve, or a structural issue called right ventricular dysplasia, or even a rare heart tumor called an atrial myxoma, can also present with these sudden falls with loss of consciousness.
So the main point is?
The key takeaway here is that
That's a lot to consider just from the cardiac side. What about when it's more about how the body regulates blood pressure, like orthostatic hypotension? I think most people associate that with feeling dizzy when standing up too fast.
That's right. The classic picture is someone feeling lightheaded, faint. Maybe their vision dims a bit, their legs feel like rubber when they stand up.
Mm-hmm.
But what's really interesting and kind of surprising is that some people, even when a tilt table test confirms they have orthostatic hypertension, actually report feeling true vertigo.
Like the room spinning.
Exactly, like a spinning dizziness that they, might mistakenly think is an inner ear problem. It's almost like a cardiogenic vertigo.
Hmm.
And get this, in some cases of profound bradycardia, a very slow heart rate, sometimes even leading to a systole or a pause, you can actually see a specific type of involuntary eye movement called downbeat nystagmus.
So eye movements linked to a heart issue causing a fall.
Potentially, yes. It really blurs the lines sometimes.
Wow. Yeah, it really shows how interconnected everything is. Okay, another major category for drop attacks with loss of consciousness, seizures. Now, I think most of us picture, the shaking and convulsing.
Right, the generalized tonic-clonic seizure.
But it sounds like seizures can also just present as sudden falls.
Absolutely. There are several ways that abnormal electrical activity in the brain, which is what a seizure is, can lead to drop attacks.
Like how?
Well, it could be through asymmetrical, uncontrolled muscle contractions in the limbs or the body's core.
Okay.
Or it could be due to a sudden loss of muscle tone. These are called atonic seizures. Literally, the muscles just go limp, causing a fall.
Like a puppet with cut strings.
Kind of, yeah. And seizures can even trigger cardiac arrhythmias, heart rhythm problems that then lead to a fall.
So it can be indirect, too.
It can. That's why a test called video EE monitoring, where doctors record brain activity and video simultaneously, can be so crucial in diagnosing these kinds of events. You need to see what the brain and body are doing at the same time.
And this happens in kids, too.
Oh, yes. In children, there are some severe forms of epilepsy, syndromes like Lennox-Gastaut and Dravet syndrome, that very frequently show up as drop attacks.
Right.
And interestingly, in children and adolescents who have these sudden falls, doctors might even do that tilt table test we mentioned earlier.
The one for orthostatic hypotension.
Yeah, they might do that first to rule out any heart-related causes before diagnosing epilepsy, just to be thorough and avoid overdiagnosis.
So they're really careful about pinning down the exact cause.
Exactly.
And what about treating these epileptic drop attacks? Are there options?
There are various approaches, yeah. Sometimes a device called a vagal nerve stimulator can help.
Okay.
Certain anti-seizure medications like clobazam, refinamide, and cannabidiol oil have shown effectiveness.
What about more drastic measures?
In really severe refractory cases where medications aren't working well enough, a surgical procedure called a callosotomy, which involves severing some connections between the brain hemispheres, might be considered. And for drop attacks that are specifically triggered by a sudden noise or startle, those exist too. A medication called lamotrigine can sometimes be helpful.
But it's not always straightforward.
No, it's tricky. It's worth noting that, paradoxically, some anti-seizure drugs can actually cause drop attacks in certain types of epilepsy. Carbamazepine in Rolandic epilepsy is one example.
So the treatment could make it worse in some cases.
Rarely, but yes. And another important point. If a stroke patient has a fall, it's easy to just assume it's because of weakness from the stroke.
Makes sense.
But you have to consider that it might actually be a new onset of seizures caused by the stroke, so don't just jump to the obvious conclusion.
That's a really crucial point. Always consider other possibilities. Okay, let's switch gears now and talk about drop attacks where the person doesn't lose consciousness. These sound particularly unsettling.
They can be, yeah. You're fully aware as you suddenly go down.
The first category here is transient ischemic attacks, or TIAs. Mini strokes, basically.
Sort of, yeah. These are often described as sudden, unwarned falls, where the person either doesn't lose consciousness at all or maybe just for a split second.
And afterward.
Immediately afterwards, their thinking is clear, they still have strength in their legs. The key diagnostic feature is that between these episodes, a thorough neurological examination should be completely normal. No lingering weakness, no sensory issues in the legs.
So it's truly transient. Which parts of the brain are usually involved?
The areas most often affected by that temporary dip in blood flow causing these drop attacks are the posterior circulation, that's the network supplying the back of the brain, brainstem, cerebellum, and the anterior cerebral arteries, which supply the front inner parts of the brain hemispheres.
Like a brief power flicker in the balance control system.
That's a good analogy, yeah.
And within that posterior circulation, we have vertebrobasilar insufficiency. What's that specifically?
So these drop attacks happen because of a temporary lack of blood flow ischemia to specific pathways within the brainstem.
Which pathway?
Either the corticospinal tracts, which control voluntary movement, or a network called the paramedian reticular formation, which is important for posture and alertness.
And are these drop attacks usually the only sign?
Rarely. Usually, people with vertebrobasilar insufficiency have a history of other TIA symptoms, things like vertigo, that spinning sensation, double vision, maybe ataxia, which is uncoordinated movement, weakness, or sensory loss.
So the drop attack might be part of a pattern.
Often, yes. But sometimes a drop attack can be a really serious warning sign. It could indicate something major brewing, like a blood clot forming in the basilar artery, which is a critical vessel at the base of the brain.
Okay, definitely serious. What else causes this insufficiency?
Besides clots or narrowed vessels, you can also see it with something called subclavian steal syndrome, where blood flow is kind of stolen from the brainstem supply because of a blockage in an artery in the arm.
Wow, complex plumbing.
It really is.
Okay, that sounds like something needing urgent medical attention.
Yeah.
What about the other area you mentioned, the anterior cerebral artery, ACA ischemia? How does a lack of blood flow there cause a drop attack without losing consciousness?
Okay, so here, the issue is reduced blood supply to the parts of the brain mainly responsible for controlling the lower limbs, specifically the motor areas on the inner surfaces of the frontal lobes.
Right.
And there's an interesting anatomical variation in about 20% of people. Both ACAs actually arise from a single short trunk vessel.
So one pipe splits into two.
Pretty much. And unfortunately, this setup increases the risk. A single small clot blocking that origin point can affect blood flow to both sides, leading to sudden weakness in both legs.
Causing the fall.
Exactly. It can even cause temporary weakness in all four limbs, paraparesis or tetraparesis. And these drop attacks can sometimes happen alongside brief, jerky movements in the limbs. They're called limb-shaking TIAs.
Anything else cause ACA-related drops?
Less commonly, things like a tear in the wall of the carotid artery, called a dissection, or maybe abnormal artery vein connections, AV fistulas, in the frontal lobe can also do it, so it's not always just typical blockages.
It really highlights how specific blood flow disruptions can have these dramatic effects.
Oh.
Okay, moving away from blood flow. What about physical abnormalities? Third ventricular and posterior fossa abnormalities. Sounds like structural issues inside the brain.
They are, yes. For instance, colloid cysts. These are benign, fluid-filled sacs found in the third ventricle, a chamber deep in the brain.
And they cause drop attacks.
They can. Interestingly, sudden, unprovoked falls are actually the second most common symptom people report with these cysts.
So that's the first.
Headaches, often ones that change depending on head position. And the tricky part is the neurological exam might be totally normal between episodes. Makes them hard to diagnose sometimes.
I bet. What else falls into this category?
Well, Chiari malformation, where brain tissue, usually the cerebellum, extends down into the spinal canal. This can lead to what some call Chiari drop attacks.
Can those involve losing consciousness?
Sometimes briefly, yes, and often surgery to relieve the pressure helps resolve the falls.
Okay.
Then you have just general posterior fossa mass lesions, things like tumors growing in that back part of the brain.
Makes sense. Pressure on balance centers.
Exactly. And even something like a pineal cyst, a fluid sac in the pineal gland, can cause problems if it acts like a ball valve, suddenly blocking the flow of cerebrospinal fluid and spiking the pressure inside the head.
Wow, like a plumbing blockage again.
Sort of, yeah. And rarely you might see posterior fossa arachnoid cysts linked to drop attacks, especially if the lower part of the cerebellum is displaced downwards. It's quite different from the historical idea of rapid head turning causing falls due to cysticercosis in the fourth ventricle.
Definitely sounds different.
Okay.
Yeah, what about inner ear issues? We have otolith crisis listed here.
Right, so during severe episodes of vertigo, that intense spinning feeling, it's not surprising that people lose their balance and fall.
Seems logical.
In fact, about 1 in 5 people with problems in their peripheral vestibular system, the balance organs in the inner ear, report experiencing drop attacks at some point.
Okay.
But a really striking example is something called Tumarkin otolithic crisis. This can happen in Meniere's disease, which is an inner ear disorder.
What's striking about it?
People having these attacks experience sudden falls without any vertigo immediately beforehand.
No spinning, just down.
Just down. They might feel like they're being suddenly pushed or even thrown to the ground. There have even been reports of really unusual movements, like someone doing an involuntary backflip.
A backflip. Serious?
Seriously. It's rare, but reported. And similar attacks, maybe not quite full Meniere's, can happen in older adults who have issues with just one of their inner ear balance organs.
That backflip is wild. Okay, the last category for drop attacks without losing consciousness is cataplexy. Usually link that with narcolepsy, the sleep disorder.
You're absolutely right. Cataplexy is a sudden loss of muscle tone, especially in the legs, but, and this is key, consciousness is fully preserved.
Yeah. So you're awake but collapse.
Exactly. It's one of the main symptoms in the narcolepsy tetrad, along with excessive daytime sleepiness, those vivid, dreamlike hallucinations when falling asleep or waking up, and sleep paralysis.
How severe is it?
It varies. It can be just a slight buckling of the knees, or it can be complete flaccid paralysis leading to a sudden fall. Once down, the person can't move, but they're breathing fine and fully conscious.
How long does it last?
Usually short seconds to maybe a couple of minutes, and it's often triggered by strong emotions.
Like what?
Laughter is a classic trigger, but also anger, surprise, excitement.
Anything else notable?
In children, sometimes you see a characteristic temporary drooping of the facial muscles called cataplectic facies. And while it's mostly linked to narcolepsy, very rarely cataplexy can happen due to other brain diseases or even as an isolated issue in families with a history of narcolepsy.
Okay, so that covers the drop attacks. Let's shift focus now to falls, the inability to stay upright during a postural challenge. First up, neuromuscular disorders and myelopathy. That sounds like a pretty broad category.
It is, yeah. It basically covers any condition that messes with the sensory input from or motor output to the legs.
Like weak legs.
Exactly. Leg weakness, especially the proximal kind muscles closer to the trunk, is a big one. Also, delays in sensory signals coming from the legs, telling your brain where they are. These lead to the gait problems you see in various neuropathies, nerve disorders.
Any specific groups at higher risk?
Well, people with diabetes have a higher risk, especially if they also have vision problems from retinopathy or issues with their vestibular system.
Triple whammy almost?
It can be. And the list of contributing conditions is long: problems with nerve roots in the lower back, lumbosacral radiculopathies, spinal cord disorders themselves, myelopathies, inherited muscle channel problems, channelopathies, issues at the nerve-muscle junction, neuromuscular transmission disorders.
So lots of potential nerve and muscle issues.
Definitely. And sometimes a sudden fall can even be the very first sign of something developing rapidly, like Guillain-Barré syndrome.
Okay. And related to that, specifically spinal cord disorders, how does damage there lead to falls?
Well, spinal cord is the main highway for those motor and sensory signals crucial for balance and movement. Damage disrupts that highway.
Makes sense.
This is really relevant in conditions like multiple sclerosis, MS, where problems with walking and balance are super common and lead to frequent falls.
And it gets worse with age.
Older individuals with MS are definitely at higher risk for injuries from falls, and they often develop a significant fear of falling, which can then limit their activity even more.
Is there anything that helps?
Yes, thankfully. It's encouraging that even for this group, home-based exercise programs specifically targeting balance and leg strength can actually significantly reduce fall risk. So being proactive can make a real difference.
That's definitely good news. Okay, next up, strokes. We know strokes cause a wide range of problems, so it seems logical they'd increase fall risk too.
Absolutely. Strokes can leave people with a whole cocktail of neurological deficits that dramatically increase their chances of falling, both right after the stroke and long term.
What kind of deficits?
Things like muscle weakness on one side, coordination and balance problems, that's ataxia, loss of sensation, vision problems, cognitive issues affecting judgment, and changes in their walking pattern, their gait.
And other factors.
Yeah, things like post-stroke depression or just being less mobile overall can also contribute.
How much higher is the risk compared to others?
It's significant, at least twice as high in stroke survivors compared to people of the same age without a stroke history.
Where do these falls usually happen?
Mostly at home, unfortunately, and they carry a high risk of injury, including hip fractures. These are particularly common in women, actually, shortly after an ischemic stroke, the blockage kind.
So hospitals try to prevent this.
Oh, yes. Concerns about these injuries have rightly led to big fall prevention efforts in hospitals and rehab facilities. Though sometimes these efforts can become a bit too restrictive, limiting movement maybe more than necessary.
But prevention programs can work.
Yes. The good news is that when facilities implement focused, well-designed fall prevention programs for stroke patients, they can be quite effective in bringing those fall numbers down.
So a proactive, thought-out approach is key. Okay, what about other cerebral or cerebellar disorders? Sounds like a catch-all for brain issues.
It is a bit broad, but there are some key players strongly linked to falls. For instance, metabolic encephalopathy is brain dysfunction due to things like severe kidney disease.
Right.
These can sometimes cause sudden, brief losses of muscle tone, especially in the trunk. It can look almost like a drop attack, a sudden buckling or near fall. It's sometimes called asterixis when it affects the limbs, but it can affect posture too.
Interesting. And the cerebellum.
Yes, the cerebellum. That's the brain's coordination center. It's a major culprit when it comes to balance problems and falling. People with degenerative cerebellar ataxias, progressive disorders affecting the cerebellum, have a very high rate of falls. And how much their walking pattern varies often predicts their fall risk.
Any other conditions in this group?
Sure, things like episodic ataxia syndromes, causing intermittent coordination problems. There's a rare inherited disorder called hypereplexia, an exaggerated startle response that can lead to uncontrollable falls.
Can that be treated?
Thankfully, yes, there are treatments for hypereplexia, and also for normal pressure hydrocephalus, that condition with excess fluid buildup in the brain.
Yeah.
A shunt, a surgical procedure to drain the fluid, can often lead to significant improvement in walking and a reduced fall risk, though the benefit isn't always permanent.
It's just amazing how many different brain areas are involved in just staying upright. Now, this next one sounds intriguing. Cryptogenic falls in the middle-aged. Cryptogenic meaning unknown cause.
Exactly. This term describes a really puzzling phenomenon seen in some women, usually over 40.
What happens?
They experience falls, often forwards, without any warning signs, no dizziness, no imbalance. They often end up with unexplained bruises on their knees.
Like they just collapse.
They often describe it that way, convinced they didn't trip, just that their legs suddenly buckled. But what's really weird is their walking looks completely normal right before and right after the fall.
How common is this?
Estimates suggest maybe a few % of women, and it seems to become more common after 40. It used to be called cryptogenic because no cause could be found.
And now?
Well, it's still an area of investigation. Research is looking more closely at fall frequency and characteristics in this specific group to understand it better. Still a bit of a diagnostic mystery, though.
Definitely sounds like a puzzle. Okay, let's zoom out to the more general aspects of getting older. Aging, neurodegeneration, and the neural substrate of gait and balance. It feels almost inevitable that balance gets trickier with age.
That's a very accurate observation, unfortunately. Even in healthy folks without specific neurological diseases, our walking patterns change significantly as we age.
How much?
Well, by the time people hit their mid-80s, very few have what you'd call a completely normal youthful gait. There's even growing evidence suggesting that just measuring an older person's walking speed could become a routine vital sign, like blood pressure.
Really?
Why? Because a consistently slow walking speed has been shown to be a strong predictor of overall mortality risk in older adults.
Wow. And we know more about the brain circuits involved now.
We do. We're understanding much better the specific brain circuits for walking and balance. There's a key region in the midbrain, plus other interconnected spots like the pedunculopontine nucleus, the locus coeruleus. They all work with big networks across the brain.
And cognition plays a role.
A big role. Cognitive functions, especially in the frontal and parietal lobes, are really important for gait and balance. That helps explain why declining stability often goes hand in hand with cognitive decline in older adults, sometimes called brain failure.
What makes it worse?
This age-related decline can be sped up by things like small strokes accumulating in the brain's white matter or neurodegenerative disorders kicking in.
Even mild cognitive issues affect gait.
Oh, yeah. Even people with just mild cognitive impairment tend to have subtle gait abnormalities much more often than their cognitively healthy peers.
Any specific signs to look for?
Well, certain gait changes are linked to higher fall risk in dementia. And one simple but clinically useful observation is the stops walking while talking phenomenon.
What's that?
If someone automatically stops walking when they try to start talking, it's often a pretty reliable indicator of increased fall risk. They can't manage both tasks at once.
That's a fascinating and practical observation. Now, huge consequence of falling, or even just worrying about it, is the fear of falling, FOF. That sounds debilitating in itself.
Absolutely. FOF is incredibly common and serious. And it's not just limited to people who've actually fallen and gotten hurt.
Who else gets it?
It's surprisingly common in people with various health conditions, diabetes, migraines, obesity, depression, sarcopenia, that age-related muscle loss.
Any gender difference?
It does tend to affect women more often and often more severely than men.
Does the environment matter?
Definitely. Fear of falling outdoors is a big thing. How people perceive their neighborhood safety can really lead them to restrict their activities outside the home, becoming more isolated.
Can it be measured or assessed?
Yes, there are reliable scales, like the Falls Efficacy Scale I. And researchers are even starting to look at the brain mechanisms. It seems like maybe reduced activity in brain areas involved in planning movement might play a role.
Can anxiety make it worse?
Oh, for sure. Fear of falling can be amplified by underlying anxiety, and in some cases, it can escalate into a full-blown phobia of falling, sometimes called basophobia.
Is there anything that helps reduce this fear?
Yes, thankfully. Structured exercise programs focusing on balance and strength are very effective. And cognitive behavioral therapy, CBT, to address the psychological side, the fear itself, can also make a big difference in helping people regain confidence.
That's really encouraging. Okay, moving to specific neurological conditions known for falls. Basal ganglia disorders, especially Parkinson's disease, PD. Falls seem almost synonymous with PD sometimes.
Yes, unfortunately, falls are a huge problem in Parkinson's.
Yeah.
It's estimated nearly everyone with PD will fall at least once, and they have about double the fracture risk compared to others their age.
What makes the risk higher in PD?
A whole bunch of factors. How long they've had PD, if they also have depression or cognitive impairment, those motor fluctuations related to dopamine medication.
The on-off periods.
Exactly.
Hmm.
Also, using sedating meds, having REM sleep behavior disorder, and especially problems with the autonomic nervous system causing blood pressure drops.
Any specific types of fall?
Some people with PD experience sudden, unexpected drops straight to the ground, often linked to those unpredictable dopamine-induced motor fluctuations. And then there's freezing of gait, FOG.
Where the feet get stuck.
Yeah, feeling like your feet are glued down. That's a very common cause of falls. Interestingly, the brain pathways involved in FOG might overlap with those involved in REM sleep behavior disorder.
Any of the factors?
Problems with cholinergic pathways in the brain likely contribute to both freezing and the general slowness in PD. And it's worth noting standard treatments like dopamine or even deep brain stimulation, DBS,
Yeah.
they don't always reduce fall risk, and sometimes DBS might even slightly increase it. It's complex. There's also growing evidence that impaired proprioception, the sense of limb position in the legs, plays a big role.
So even with guidelines, it's still a challenge.
Absolutely. Despite assessment and prevention guidelines, falls remain a very persistent and difficult issue to manage effectively in Parkinson's.
It sounds incredibly complex. What about progressive supranuclear palsy, PSP, and other Parkinsonian syndromes? Similar issues to PD or different?
There are definitely overlaps, but also key differences. In PSP, falls are often one of the very first symptoms, and they tend to be backwards falls more often than in PD.
What else characterizes PSP falls?
Well, PSP involves Parkinsonian features like slowness and stiffness, but also rigidity, spasticity, and those specific eye movement problems, especially looking down. Brain imaging shows different patterns of involvement compared to PD or normal aging.
Any link to sleep disorders?
Yes, REM sleep behavior disorder is often a precursor to PSP and can cause falls out of bed.
So similar mechanisms, but different brain areas affected.
Broadly, yes. Similar mechanisms related to balance and motor control contribute to falls in other syndromes too, like multiple system atrophy, MSA, or Lewy body disease. But in Lewy body disease, the cognitive impairment, those fluctuations in alertness and visual hallucinations, adds another significant layer to the fall risk. Each syndrome has its own flavor of challenges.
So across all these conditions, falls are just a major issue. Let's zoom out again to the age state itself. You mentioned earlier, most patients presenting with falls are elderly.
That's absolutely correct. About a third of people over 65 fall each year. And as we get older, both the chance of falling and how badly we get hurt tend to increase.
Why are injuries worse?
Several reasons. Our bodies are less able to absorb the impact. We lose some of that natural padding, the soft tissue around joints, and conditions like osteoporosis make bones more fragile.
Where do most falls happen?
Sadly, the highest rates are in sheltered housing or nursing homes.
You mentioned gender differences earlier.
Right. Women tend to fall more often and have more fear and fractures, but men, when they fall, have higher rates of traumatic brain injury, TBI, and are more likely to die from the fall. The circumstances around the falls can differ too.
And what about medications like blood thinners?
That's a big concern. The risk of brain bleeds after a fall if someone's on anticoagulants or antiplatelets. Even low-dose aspirin isn't entirely simple in this context. If someone on warfarin has a fall and an intracranial hemorrhage, their risk of deterioration is higher.
So falls are a major cause of death in the very old.
A leading cause of injury-related death, yes. Complications from TBIs and hip fractures are major contributors. It really hammers home the need for prevention.
Absolutely. And it's not just specific diseases, right? The actual physiological changes of aging contribute heavily.
Totally. As we age, lots of things normally decline, and they all add up to increased fall risk.
Like what?
Our sense of proprioception dims, we lose muscle mass and strength, that's sarcopenia arthritis and other orthopedic issues become more common. Obesity rates increase, cardiovascular function might decline, vision and vestibular balance function aren't as sharp, cognition can slow, and our postural reflexes, the automatic adjustments to stay balanced, become less effective, sometimes called presbyostasis.
So like a perfect storm of small declines.
Exactly. It's the cumulative effect of multiple, often subtle, age-related changes that really cranks up the fall risk for older adults.
Okay, so given this huge web of potential causes, how do doctors approach the clinical evaluation when someone comes in reporting falls? What's the process?
Well, the main goal is twofold. Figure out the likely mechanism of the fall. Was it a trip, a faint, a drop attack? And identify any underlying medical conditions or risk factors that can be treated or modified.
How do they do that?
A detailed history is crucial. When did the falls happen? What were you doing? Any symptoms beforehand? Though remember, if someone lost consciousness, like with syncope or maybe a seizure, they might have amnesia for the event itself.
So the lack of memory is a clue.
It can be, yes. Then checking for orthostatic hypotension is key, measuring blood pressure lying down then standing up. Also, checking for blood pressure drops with head turning. These can point to problems with the autonomic nervous system.
Is there a standard definition for orthostatic issues?
The exact numbers can vary slightly in definitions, but significant drops in blood pressure on standing are definitely strongly linked with a history of falls and symptoms like dizziness. And severe orthostatic problems, like failure of systolic blood pressure to recover after standing, that's actually a predictor of increased mortality risk, so it's really important to assess.
So a really thorough investigation is needed to piece it all together. Okay, finally, let's talk intervention and prevention. Given how common and serious falls are, what actually works?
Recognizing someone's increased risk is the absolute first step, and thankfully there are established clinical guidelines to help doctors identify who's at higher risk.
And once identified,
Interventions really need to be multifaceted, tailored to the individual. It's not a one-size-fits-all thing.
what kind of things are involved?
Well, providing appropriate assistive devices, canes, walkers if needed,
Yeah.
actively treating underlying conditions like heart rhythm issues or low blood pressure, making home modifications to remove hazards, loose rugs, poor lighting, clutter.
What about medications?
Definitely reviewing medications, stopping or reducing things that increase fall risk, if possible, sedatives, certain blood pressure meds, sleeping pills, etc.
Any simple advice?
Wearing sturdy, low-heeled shoes is always a good recommendation. Simple but effective.
And exercise.
Hugely important. Balance training exercises. Tai Chi is a great example, and exercises to improve lower body strength and endurance have consistently shown benefits in reducing falls.
What about the fear of falling we talked about?
Addressing that is crucial too. Behavioral therapy, strategies to build confidence, often alongside the exercise.
Any longer-term strategies?
Sometimes things like vitamin D supplementation, cataract surgery to improve vision, maybe even statin treatment for fracture prevention in some cases, but it's complex.
How so?
Well, interestingly, some studies found a temporary increase in fall risk right after getting new glasses, maybe due to adaptation. And very high annual doses of vitamin D might also paradoxically increase risk compared to more regular dosing.
Anything else surprising?
There's some debate about standard walkers, whether their design might subtly affect gait in a way that actually contributes to falls for some people. It's counterintuitive, but being looked at.
So it's not all straightforward.
Not at all. While exercise is generally great, the benefits can vary. And for some groups, like people with dementia, or if the exercise is too intense, there might even be risks.
What about technology?
There's a lot of development there. Wearable sensors to detect falls, low-stiffness flooring to cushion impact, protective hip shells, and just the basic but vital step of screening older adults routinely for fall risk and getting them into prevention programs is key. It remains a challenging public health issue.
Wow. It's incredibly clear that falls and drop attacks are just tremendously complex issues. The range of potential causes is huge, isn't it? From specific heart and neurological conditions right through to the general gradual process of aging itself.
Absolutely. And I think the crucial takeaway for you, the listener, is that really digging into the specific circumstances around a fall, what happened, were there any other symptoms, even subtle ones,
Hmm.
is absolutely essential for getting to the right diagnosis and finding the best way to manage it.
Yeah, it's not just about the fall itself, is it? It's about what that fall might be signaling about someone's overall health.
Precisely.
So, thinking about the huge personal costs, the injuries, the fear, and the massive societal costs we talked about, it really makes you wonder, what are the most promising paths forward for research and intervention? Should the focus be more on pinpointing and tackling those individual risk factors, the medical conditions, the medications? Or perhaps are there broader public health strategies that could have a bigger impact? Things like modifying environments, community-based exercise programs, maybe even policy changes. It seems like this intricate dance between our individual health, the places we live and move in, and our daily habits and behaviors, they all play such a critical role in understanding and hopefully preventing these potentially life-altering events.